evidence-based medicine. You have heard this a lot. When he was practicing medicine, when I was practicing medicine, evidence-based medicine didn't exist. Okay? And we would do sometimes things by case studies, or we would do by anecdotal basis. But now evidence-based medicine, and evidence-based medicine says the following. I could do my trigger points with lidocaine plus a steroid. I could do my trigger point with lidocaine alone, or I could do my trigger point by dry needling. And all three have shown, according to evidence-based medicine, to be as effective. So I could use lidocaine and steroid, or dry needling. So if I use lidocaine in any combination, whether by itself or whether with the steroid, the improvement is going to be immediate if you're doing it right. Because remember, the onset of lidocaine is almost immediate. The duration of lidocaine is approximately 1 hour. So therefore, once you do this, most of my patients will have immediate improvement, and that improvement normally is greater than 50%. So they may have some discomfort still, and one of the things that I normally tell them is, don't think of the discomfort that I caused by giving the little shots, but think of the discomfort you had prior to the shots. And so now they say, oh, okay, well, about half. Now, and remember, we mentioned this yesterday, and I can't stress the importance of this. If your patients, most of your patients are having a pain intensity of 9 or 10, is because you're not directing questions correctly. So, tell me that your pain is a 10. So, sir, you're having back pain?
Yes, I do.
Okay, and the intensity of the pain between 0 and 10, 0 being no pain, 10 being the worst possible pain, what number do you have right now?
No, I have 10 right now.
At 10. Okay, now this happens many times. The patient is sitting down, legs are crossed, and they're telling me that their pain is a 10. In addition to that, they're flexing their back to 90 degrees, which significant increases intrathecal pressure in case they have any disc pathology. So a 10. Okay. So if you ask that question like that, you're going to have a lot of 9s and 10s. A lot. But this is what I tell him. Sir, I'm going to tell you what a 10 is. A 10 is, and I make even the motion. A 10 is, I'm coming at you with a chainsaw, and I'm chopping off your leg. That's a 10. Nothing else but that. Now, between 0 and 10, what is your pain level?
9.
Okay, 9. So, and that will happen. So, and are you having that 9 right now?
Yes.
Okay, so if that happens, I immediately call the nurse and tell them that he needs to be transported to the emergency room, because the pain, first of all, is not a pain that I should be treating in my office. I should treat this patient in the emergency room. So I'm going to call the ambulance. I'm going to have my nurse call the ambulance right now. Is your pain still a 9 right now?
It's better, it's 8.
And that's what will happen. They will decrease. Now, let's say they decrease their pain intensity. You can't get them any lower. So this is my next question would be, now an 8 is when the pain is at the worst. Isn't that right?
Yes.
And you see, you get them immediately. So now we have that the maximum pain intensity is an 8. So that should be with medication, without medications. So what is your pain level with medications?
8.
So if it's the same, because he told me it was an 8 without medications and an 8 with medications, my next answer to him will be, sir, if you have been receiving narcotics and your pain is the same with narcotics as without narcotics, I'm going to stop all narcotics. Now, I know that I can't stop all narcotics because if I stop all narcotics, what's going to happen? He's going to have a withdrawal syndrome. Anytime you decrease the opiates in greater than 50%, that's the cutoff, the patient may have a withdrawal. So I know that I need to reduce his narcotics at least 50%, but he doesn't know that unless he has a medical degree. So I need to stop all your narcotics because they're not working. Is that your final answer?
7.
So now he comes down. So you see, this is the way that I want you to think. This is important. I'm going to tell you, if you're writing for opiates and the state board gets hold of you, and the reason they're going to get hold of you is because last year you wrote a lot less narcotics than this current year, and guess what? They get reports from pharmacies, and if now they look at the bell curve and you are in the 85, 90 percentile of physicians prescribing narcotics in your state, guess what? You're going to be called. And they're going to review your medical records. And if your medical records show that the patient with pain has, without medications, has an 8, and with medication still has an 8, guess what's going to happen? They're going to say that you have substandard of care. You have deliberate substandard of care. And you will be penalized. That's the bottom line. If you don't see, or let's say that the patient is a symptom magnifier, or he's a malingerer, which is difficult to make the diagnosis, don't use the term malingerer loosely. Because malingerer, you need to know the definition of DSM-IV. If you don't know that definition, don't use the term malingerer. And if you're not familiar, look it up, the DSM-IV. But in order for you to be a malingerer, you need to have an antisocial personality. From the first time that a patient comes in, I don't know if he's going to have an antisocial personality or not. Because first, and these are antisocial traits. Sir, would you please have a seat? I can't. What do you mean you can't? You came in a car walking. If you came in a car, you could sit, right? True or false? So every single patient that comes to you, unless they were transported in an ambulance, they came sitting, unless they came walking. So if they came sitting, can they sit for you? Yes. So that's an antisocial. Sir, can you bend at your waist? I can't. It hurts too much. Antisocial traits, because they're not paying attention to my instructions or commands, and they just refuse to do whatever you tell them. Can you reach down and touch your toes? I can't. Can you twist your body to one side? I can't. So all of these are antisocial behaviors. So all I would know in that, especially in that first visit, is that this patient has antisocial traits. Okay? That's all I know. So I don't use that term malingerer loosely. Instead, I use the term symptom magnifier. And then now I know, and I identify this patient, and it's for the lumbar region. There are some signs called the Waddell signs. Who's familiar with the Waddell signs? Okay, if you're examining backs, you need to describe the Waddell signs if you're examining backs. And again, this is just pearls that I'm giving you, sir. Come, brother, over here. Come over here. So these are some of the Waddell signs that I'm going to teach you real quickly. One is called, now this is for the lumbar region. Waddell wrote an article in Pain in 1990 that became the gold standard for symptom magnification. And basically, the first one is what is called simulated, write it down, axial compression. So I'm going to place my hand over the top of his head. Exactly, and that's what they will do. Now, I'm sure it's called simulated because I'm not applying pressure. And if I apply pressure, I just go like this, like something like this, gently. And he goes, are you having pain, sir, in your lower back? Okay, so that is one. So simulated axial compression. The other one, I'm just going to do it over this. Remember, I tell them to take off their clothes. This is for illustration only. So the next one, when I touch you, you start, is light tenderness. Is that hurting you, sir?
Yeah.
Okay, now that's all I'm doing. Light tenderness. But they're complaining of pain. That's another Waddell sign. Another Waddell sign would be when it's called pelvic rotation. Now, this is important, guys. When I rotate the pelvis, the lumbar spine should not hurt. So I tell them, put your feet together, hands to the side. I'm going to go ahead and move you. You don't move. I will move you. And if there's any discomfort or pain, you let me know. So now I do this.
Ooh.
And I go this. Where does that hurt, sir?
My back.
The back. Now, if there was anything that would hurt, it should be in the pelvis, but it's not. So this is another one. So it's called pelvic rotation. Another one that is important is trochanteric pressure. Now again, if I apply pressure in the greater trochanter of the femur, there's no reason why he should have discomfort and pain in his lumbar region. So what I do is come with my hands. I'm going to put my hands in the greater trochanteric region, both hands. This is for illustration. And I'm going to apply pressure with both hands. One here, one here. Now, should that cause discomfort and pain in the lumbar region? No. And my favorite one, now overdramatization is another one. That's something that is part of the art. Overdramatization is when they go, oh, doc, this is killing me. This pain is killing me, doc. Can you sit down? No, I can't sit, doc. Okay, well, just stand there. Oh, I can't stand too long either, doc. Overdramatization, okay? Or if I touch this, they'll collapse to the floor. Overdramatization. Sir, I'm going to examine your knees, okay? Are you having any problems with your knees?
Yeah.
Any problems with your knees? And while I'm talking about his knees, I'm doing a straight leg raise. And this is a straight leg raise of 90 degrees. Now, I'm not going to coach him to whether or not he's having discomfort, because he would have to tell me. So let me check this other knee. Is the knee hurting you?
Yeah.
The knee is hurting you? Mm-hmm. Okay, but I don't give a blank about the knee. I'm examining the lumbar spine, okay? Now, so he thought I was examining the knee. So now go ahead and lay back, sir. Lay back. And now I'm going to be doing a straight leg raise. Now he knows that if I'm doing a straight leg raise, it's going to hurt where? In the back. So the first thing I do is I start with my straight leg raise. Is that hurting you, sir? Okay, now there's several things here, very important. If the straight leg raise causes discomfort and pain at 30 degrees or less, the patient is definitely magnifying. Why? Because you don't increase the intrathecal pressure unless it increases more than 30 degrees. So when I'm going about 35 degrees, I may reproduce some of the radicular symptoms. Now remember, the straight leg raise also is not pain in the back. Remember that. The straight leg raise is to reproduce the radicular component of pain. So is this hurting you? I didn't ever say this, but it just is. Okay. Is the pain in your back, or where is your pain?
My back.
Okay. Does it move anywhere into your buttocks? I don't tell them into the legs. Okay. Anywhere else?
A little bit in the leg.
A little bit in the leg. Does it move? Does it go to your knee or below the knee?
Just up to the knee.
Up to the knee. So now I know that is not radicular component. But what I wanted to get is this. If there's a difference in the straight leg raise greater than 20 degrees, let's say he's having pain here, which is about a 35-degree angle. If there's a difference greater than 20 degrees between the seated straight leg raise and the supine straight leg raise, that is a positive Waddell. Why? Because physiologically that's impossible to have. And the pain for the straight leg raise, because I've seen this with residents all the time, straight leg raise is positive. Well, what exactly do you mean by a positive straight leg raise? Oh, the patient is having pain in his back. Anything else? No, that's basically what he had, that he had pain. Well, that's not a positive straight leg raise. The straight leg raise has to have a radicular component, and the radicular component has to go below the knee. And the reason why below the knee is because 95% of all intradiscal pathology is at the L4, L5, or L5S1 region. So if you know how to identify those levels, 95% of all pathology is there.